Dr. Carmen Pugliafito. Welcome to Retina Synthesis. We have Dr. Lejla Vajzovic with us today. She's an associate professor of ophthalmology at the Duke Eye Center and an expert on both adult and pediatric ophthalmology, retina-wise. And we're going to talk today about lessons learned in retinal gene therapy. So Lejla, welcome.
Thank you, Carmen. It's a pleasure to be here.
So what's been your experience with retinal gene therapy so far?
Yeah, no, I think in general, it's a very exciting field. I think there's much to be offered. Clearly, we're just hitting the tip of it and getting sort of warmed up with it. But I think it's very interesting. I think out of all of it, in terms of gene therapy, I think transvitreal or subretinal delivery approach, it seems to be the most optimal in terms of what it's delivering, promises, but in terms of the side effects as well. So I think that seems to be the most promising so far.
Mm-hmm. So you gave a very nice talk recently at the clinical therapy clinical trials summit, talked about lessons learned in retinal gene therapy. What are the main lessons that you've learned?
Yeah, I think in general, just like when we are approaching any type of surgery, we want to kind of dig into the details of it. And I think for gene therapy, some pre-planning needs to be done. I think there's vast difference between adult and pediatric eyes, but not just between that, there's a vast difference between diseases at stake. So I think for somebody who's getting gene therapy for AMD, I think the approach in that surgery will be a little bit of a different mindset versus somebody who is a pediatric eye with inherited retinal disease. I think those eyes will have a little bit more adhesions in terms of RP and retina, and that blood may be a little harder to initiate for sure and propagate. And I think I focus a little bit more talking about gene therapy for age-related macular degeneration, kind of emphasis on that. And I think when we approach an eye, we want to think about first the target area. We want to analyze our images preoperatively and understand what are the goals for that clinical trials, where exactly the drug does need to be delivered, and where we want to initiate that bleb. And I personally like to print out a fundus image and literally label on it, like what is my first location for the injection, what it would be my second, third, and such in case needed. I think over time for Regenxbio's Bio study, there has been a shift to initiating blebs inferiorly. Infranasal, I think, is the optimal location because we have seen some RP type of changes secondary to, who knows, maybe technique itself, delivery technique, or the virus self-transfection of the virus. And we want to limit those to access to the macula. So I think first foremost is target area, pre-planning, where you exactly want to start. I think next one in terms of operation itself is making sure you are very thorough in your vitreous removal. And for, I think, age-related macular degeneration, that might be a simple task of ensuring you've done a thorough vitrectomy and peripheral shaving. But in pediatric eye, that will definitely need a highlighted with a triescence and ensuring that we have a full PVD induction. And even after that, I would again restain and rehighlight the pictures to make sure that all of the hyaloid surface has been eliminated. There's often low vitreous scases and residual hyaloid on the surface of the retina that will very much limit your induction of a bleb. It will plug your tip of your cannula and it will not allow you to propagate that or even initiate it. So I like to use the flex loop, nitinol loop, to help me eliminate any of the residual hyaloid by gently kind of scraping on the surface of the retina and eliminating that in the area where we're going to be initiating the blebs. And after that, it's all about kind of focusing on initiating that bleb and the location you chose. I think for initiation itself, you want to make sure you've done the due diligence of decreasing intraocular pressure, because we don't want that intraocular pressure resisting the pressure, the flow of gene therapy delivery and initiation of the blood. So I like to drop my intraocular pressure down to 10. Most of us now these days use IA vitrectomy machines that have IOP feature included, IOP control feature. So I like to actually turn that off because I don't want that to be blasting or infusing additional fluid to make up for the decreasing in pressure. And then after I've adjusted that, I like to kind of focus on the area where I'm going to inject. And with the cannula, we're kind of gently touch the surface, see sort of a grayish pimple, grayish change. If it's more of a whitening change, then that's probably we're pressing a little too much with the cannula, and then start the bleb. If we're hoping for this bleb to be in macular location to involve the fovea, we definitely want to initiate it in the macular within the arcades. If we are hoping for this bleb to be peripheral, like in Regenexx Bio studies, we're going to be initiating it outside of the arcades. And typically, the bleb will propagate away from the arcades or away from the macula if you're starting more in the periphery. And then I think the injection flow, as we're learning with some of the kind of side effects we're seeing, or some of the pigmentary changes we're seeing down the road, there is some speculation that might be surgically related. So all of us are very much in tune to injection pressure. And I like to use the automated feature on our vitrectomy machine with a little Med1 connector, where we can use the viscous fluid inject feature and Med1 connector to help us automatically do the pressure control. So I like to lower my PSI down to 16 being the max, and I actually like to use more of a 6 to 8 PSI range, or maybe even lower once we've started that bleb, to help me slowly propagate the bleb and slowly inject and enlarge that. And once we're kind of we're following very closely what's happening in the surrounding areas. If this is within the macula, I want to make sure that a fovea eversion is slowly happening. And that's where I feel like OCT helps me the most, is following intraop OCT is helping me understand how the fovea itself is behaving. If there's too much of a version of fovea, I may stop at that point with a concern that there may be a macular hole formation down the road. So that is the step that's kind of crucial in understanding, in my opinion. And if this is a peripheral bleb, we're monitoring to make sure that we are delivering outside of arcades and we're staying there. And then we're tasked with following how much volume we're injected. And I think that's actually a very challenging task, because we're focusing on the area in front of us, focusing on that bleb, and somebody else is holding potentially that syringe and reading out for us. I have my system reading out loud where exactly was started, and we continue to count down to the volume that needs to be injected. And I think while we aim to inject 300 microliters or whatever the volume is of that study, it is often a challenge to be, I think, an exact precise kind of method. We aim for it, but we're finding out from some of the OCT studies that we have done that we're probably pretty imprecise in our measurements. But that can be also not just volume delivery, could be technique related as well. And then the last step is making sure you're not coming out of that retinotomy you created, you're staying in it till you are certain you deliver the volume. And if you're questioning, it's better to then come out, kind of wait it out and start a bleb elsewhere, versus going the same bleb and continue to enlarge that retinotomy, because we all have seen reflex of fluid coming through that area, and we definitely don't want to make it larger than it is. So those are kind of in summary, steps of the things as I go through and things. So in terms of thinking about how to generate this bleb and where exactly to start it.
What do you use for your micro injection? What device, what system?
Mm-hmm. So I really like the extendable 41 gauge needle that is designed by Dork. It is retractable, so I like to retract it. It is a 23 gauge instrument, but I do like that feature of being able to extend it, so I make sure I'm not in any way injuring the tip as I'm going in and out through the valved cannula system. And once I extended it, I feel it's visible because it has a little coloration to it, yellowish tip, and I can kind of visually see where exactly it is. I wish it was an instrument that I can very much see on an intraop OCT, because I think OCT helps us guide more so than any other surgery, helps us really with gene therapy delivery. I think there's yet to be an instrument where it's very much OCT friendly. We can visualize the tip, but we can to a certain degree tell this. And then the last thing is I do like to bevel it. Some trials or Regenxbio would prefer not for us to bevel it, but I actually like to cut it on those that do allow it, because I think that allows you to be a little bit asymmetric in your entrance and subretinal location and to initiate that bleb a little easier.
Do you do an air fluid exchange at the end of the case or not?
I do. I think it's important. Definitely, if I'm not doing fluid air exchange, I'm definitely doing fluid exchange. As much as we think we haven't had any reflex, so we were very precise in reaching that subretinal location, there's definitely much egress of fluid happening, and we definitely don't want to. We don't want that happening and virus transfecting other areas besides the photoreceptors and RP.
So how often would you do the air fluid exchange compared to the fluid exchange?
At least 2-3 times. Sometimes I leave it under air because I want to make sure that if it's if we have to target the macula, I want that air to help me kind of push the fluid even more posteriorly as we're doing it. So, but I sit in the fluid for a while and just take a couple of minutes just exchanging fluid for fluid as well.
Mm-hmm. What about post-operative management of these patients? What do you tell them? I mean, particularly the parents of the children.
Yeah, I typically, in kids, I tend to, unless I haven't reached the fovea, I'll leave them under air, a little bit of air to help push out. But I tend to leave them under fluid more so because we can't position them very well. And then I find that air may be actually pushing the bleb even more inferiorly and maybe causing displacement if we have a very large volume that we had to deliver. So I tend to, luckily they're pretty sedated right after surgery. So I have them laying on their back, more in supine position for at least a couple of hours. And that's for any type of delivery to the macula. I want that fluid to kind of drape or settle as much as possible over the posterior pole. And then for the rest of it, I don't have any restrictions besides of no rubbing your eye, no striking strenuous activities to like potentially, if I didn't use sutures, I don't want that eye to become hypotenuse in any way.
What about the adults? Anything difference with them?
Not much more difference as well, because I tend to use minimal air at the end just to kind of help me, yes, exchange, but potentially close or seal sclerotomies off, but no additional restrictions for them either.
What about intraoperative complications? What are the most frequent ones that are observed?
Yeah, I think the kind of the dreaded one is you have to be very careful of target location and staying away from arteries and making sure that you don't have any intraop bleeding, specifically subretinal bleeding. One would definitely want to kind of stay away from that. I think there have been instances where one would potentially inject the product in sub-RP location. So there's like a little PED at the site. And I think OCT helps us know that we're in correct location as we start to initiate that bleb. So I think that would be one of the kind of dreaded things that one would want to stay away. And then I think vitrectomy itself comes with the risk of, during induction of PVD, you come a risk of having a retinal tear created during that induction. I think anytime you have any of the additional steps that you need to undertake, like sealing that off, it's not a dreaded. It's something that I think it happens for certain during vitrectomy surgery. It's given that risk is there, but you want to just have minimal things happen during these procedures.
Do you have an opinion about subchoroidal, suprachoroidal delivery of genes?
Yeah, I think I think just recently in Retina Society, we've seen really exciting data so far out of Regenxbio trial coming out. It looks like they've not had any inflammation. I think number one question with all of these is inflammation, right? What is it? What is this gene therapy going to, do in that particular area? I think with subretinal approach, we've seen that it's really immunoprivileged site, and then we're having minimal issues with inflammation. And I think that's why it continues to be, in my opinion, the approach to go. Intravitreal definitely has had issues, and I think the younger the eyes, the more inflammation is going to be. And I think that's why in diabetic trials, you're seeing that more so than others. And then in suprachoroidal, I think I was excited to see that there's minimal issues with inflammation. So I think from that perspective, seems promising. I think the efficacy has to be teased out, but I definitely, I was happily surprised to see no inflammation issues.
Do you have an opinion about which delivery system is going to be the dominant one in the future? I mean, that's looking forward a number of years.
Yeah, I agree. I wish I wish it would be intra-office procedure. So while I'm very much pro subretinal delivery, I think surgery comes with the risks. Although doing that once and having a product that is, biofactory for the rest of someone's life, I think it's a risk I'm willing to take for that patient versus expose them to continued injections in clinic. But if we can figure out an outpatient approach where we are doing intravitreal or suprachoroidal injection, I think that would be the approach to take. And so far, suprachoroidal looks very promising in terms of inflammation. I think efficacy, I hope to see that there too.
Well, thank you so much for this discussion. It was really terrific and lots of great points. And I know that our audience will enjoy listening to this. Thank you so much for your participation on Retina Synthesis.
Thank you. Thank you. Thank you, Carmen. Have a great day.